thanks so much for joining me.
Thank you, Matthew, for having me.
Yeah, absolutely. This is going to be a fun one. I've worked a lot on the home healthcare side, but actually talking to somebody that's lived in the discharge coordination side is interesting. It's not as a selling tech, it's not something that I've got to really have a ton of those conversations in the past. So before we jump into everything, do you want to give a little background on yourself?
Sure. So I have my master's degree in social work. I also have my ACM, which is accredited case manager, and my CMAC, which is a case management administrative certification. I worked in acute care, both bedside and leadership, for 20 years. I actually had responsibility over a home health company that was owned with our health system for a couple of years. And then I moved into the vendor space where I started providing technology and services to support case management departments, as well as doing some case management consulting for about 15 years. The last 15 years I've been doing that. And I keep my hand in what's happening in the community and try to stay as up to date on compliance and regulatory changes and updates as much as possible in my current role.
That's awesome. So you worked for an organization, a health system, and you were over case management and home health. So you got to see a lot of that interaction, or lack of sometimes, I'm sure. Where was that at? And kind of fill us in on some of that.
So it was actually in Phoenix, Arizona. I worked for Banner Health, and we were putting together a case management resource center, trying to centralize some of the more administrative pieces of that transition of care and sending the referrals out. And that was actually sat within the home health building, and they also reported up through me.
That's awesome. That's very, very cool. So I guess in that experience and going through all of your past experience, having some of that home health knowledge, I mean, what were some of the things when you were maybe in the case management role or discharge coordination role or leadership role that you wished some of those that you were referring to, home health care agencies, maybe knew a little bit more about, or some things that they would adjust or have changed to make the transition of care process more seamless?
You know, it seems like the biggest gap was always understanding what the goals of the hospital were, why the transition was so critical to ensure that it was a timely transition of care, and making sure that we had clear communication. I think for both sides, there tends to be a lack of communication that happens. There's not always consistent sharing of information, whether that be what happened throughout the hospital course down to the home health company, or what the planned start of care and next steps back into the hospital communication. So that was always a gap that I saw for both sides. And just really understanding, you know, the throughput that needs to happen in a hospital. And we've seen so often that people look at discharge planning and discharges as being the bottleneck, but where it's actually being driven is in the emergency rooms. We get such a backlog of patients needing those beds that it does become critical to keep that patient moving. But at the same time, it has to be patient-centered. We have to consider what the outcomes are and the impact on the patient's journey and tying it all together. And I've always told staff on both sides, if we can all keep the patient at the center of what we're doing, I think the other pieces automatically improve.
For sure, yeah. And so communication is obviously a huge piece of that. I mean, I think that's with everything, right? It doesn't really necessarily matter the business. The outcome is the customer at the end of the day, and communication is key. So with that being said, the communication being key, I think obviously we are in a constraint of time, energy, and effort in the healthcare space. So let's talk a little bit about more about resources, flexibility. Obviously, you don't know how many patients are going to be ready to be discharged from the hospital every day, and agencies don't know how many patients they are discharging, or maybe other referrals that they're getting across the scope of their referral sources too. So from other hospitals and community physicians, so forth. So I guess maybe what are your thoughts there?
It's a hard one, especially in this post-COVID age of healthcare. We have a personnel crisis across the country, across the world, really, in healthcare and many industries. And I think that has always been a barrier in those transitions, having the resources available to see the patient as timely as possible. We've seen for years that one of the primary causes of a patient readmitting to the hospital is their lack of understanding of what comes next. They go home, they have all these new prescriptions, they still have all these prescriptions at home. So what do? They take them all. And it creates this crisis where they bounce back into the hospital, where if we had the resources to be able to get into the home fast enough to do that med rec, to look at whether or not they are truly able to function, because what we see in the hospital, what they say they have available to them may not be the reality once you get someone in the home and putting eyes on what's happening. I used to really push my physicians to order those home safety evaluations when I was pushing patients out. I worked in a medical unit, and we kind of got all the very complex patients would discharge out of our unit, and it just became a standard. If I was sending somebody home with resource at home to support them, I wanted a home safety eval. So we could look at what we could do to support that patient. But that fails if there's not a resource available and flexible to be able to get in the home quickly. I don't know what the solution is to have that. It's definitely a game that we even played staffing in the hospital with being able to staff up and down based on census. I think it would be interesting to see the different levels of care come together and look at how they each do that. And, we see trends. We know there's always trends in census and what we have happening. We see that boomers are wanting to age in place today. They're not wanting to go into facilities. So knowing that, it seems like we should be able to use data to predict a little bit better than we do today.
Yeah, absolutely. Well, and I think sharing of ideas and sharing of what works isn't happening enough in this space from what I've experienced, because it's kind of a market competitiveness thing. But if it's at the end of the day, if it can seamlessly create this communication process up and down the channel, if you will, and it becomes kind of a standard, and it's actually helping the patient at the end of the day, that would be a beautiful thing. I mean, obviously, we've got a ways to go, right? But with that said, so I mean, are there any type of maybe strategies that you've seen across other type of post-acute providers that they use to better communicate what their resources and their availability is with the hospitals that help kind of balance some of that, maybe getting from getting less proactive and more, getting less reactive and more proactive to that communication approach?
Oh, 100%. I see it all the time where skilled nursing facilities are sending out messages to all the hospitals in their area, letting them know what their bed availability is, especially moving into a weekend, being able to better drive that communication. We saw the push years ago where hospitals don't want liaisons combing through the hospitals, trying to promote getting their patients through donuts and gifts and those things. But the communication part still has to be there. Like, we still need to know, hey, I have bandwidth. I have a telemonitoring program that we've started up, and we're looking for starts of care on that. If you have anyone, finding the tools that are out there, there are technology tools that allow those mass communications between post-acute providers. But there's also the old-fashioned telephone, picking it up, or I've seen them send a fax in, which still cracks me up today, that it'll come off the fax machine saying, we have beds available. Is there anything I can do for you? But getting creative outside of just bringing gifts and really making it back about the patient, I think, is where we're seeing it move to for today. And it's what we need more of in all levels of care.
Yeah, for sure. And it's a lot more about consistency over intensity, I guess maybe it'd be the best way to put it, right? And they have the new initiative. They do it a bunch of times really quick, and then it just falls flat rather than, okay, hey, let's just make this a standardized process. And maybe somebody will fall in line of being used to this, right? I mean, then it just becomes a standard process.
Say, think about how many emergency departments now post what their wait times are. Like, there's billboards here in Phoenix that you drive and it'll have a ticker on it saying what the current ED wait time is. So it gives patients a better idea of where they can get immediate care and not have those long waits. It's kind of the same concept. We just need to stretch it across other levels of care and make sure we're getting it communicated to the right people.
Yeah. So, I mean, if you're a discharge coordinator and you know that there's 6 potential agencies that they told you this morning they got bandwidth, those are probably going to be the 6 first agencies that you show to that patient, if you will, because, hey, if I'm going to try to get this patient out of my hospital, I know that this morning they said they had bandwidth, versus you sending out a mass message to 27 different local home healthcare providers and waiting for the first person to take them back.
100%. And, on the hospital side, the conditions of participation require us to offer patient choice. In the past couple of years, it has been clarified with CMS that we only have to present those that are available. So if we know you're available, then those are the ones that we have to present. To offer that choice. And it creates just a better experience for the patient. I can't tell you how many times I would take my list in and the patient's like, I want ABC company. And I'd be like, I've already talked to them today and they have nothing. And they're like, well, that's the only one I want. And it's like, need another choice because they're not available. So when you're presenting them options that aren't options, it just creates distrust, frustrations, and that tends to impact outcomes.
Yeah, absolutely. Absolutely. Well, and it doesn't look good on the home healthcare side either, right? It's like, well, why aren't you available? Because the patient doesn't understand that the industry constraints, whether it be time, resources, money, except, so on and so forth. Maybe they don't have that type of specialty program. No, that's really, really interesting.
Or take that insurance.
Yeah, exactly. Or take that insurance. They're out of network. All right. They can't even take you because they can't afford to care for you. No, that's a really, really, really good point. So from a data perspective, sharing, a data and maybe metrics, outcome metrics perspective, what were you looking for in your home health relationships? On either side of that, easiest way to communicate, or just the data and the metrics that you guys would evaluate of who do we even, want to show that potentially could be a valid candidate for our provider for this patient?
In my health system, we actually had applications that we sent out to all the local, and we had them present quality data back to us through their OASIS or MDS, whichever level of care it was. And the kinds of things that were important are tied to patient outcomes. What is your readmission rate? I mean, if you're bouncing back every patient, successful return or remaining in the community. If that's important to my patient, that's important to me as well. some of those star ratings today, let's be honest, they're very subjective. Those aren't important to me. What's important to me are those that I can measure and see. There's no way to fudge this data. That's either you did it or you didn't. So that kind of information is key. But the other part of that is how you're able to work with me at the hospital. Are you flexible? Are you taking the complex patients as well as the easy patient? Because that matters. And that's also, in my experience, impacting your quality data. If you're taking, 50% of my extremely complex patients, you're probably bringing your score down a little bit. So that's important. And as a discharge coordinator, it's pretty common to have your patient say, well, what do you recommend? And it's like, well, I can give you details. They, well, no, if it was your mom, what would you do? And sometimes my response was, I've had a lot of success with these 3 companies really treating patients well and working very well with me, because that matters. And that says a lot about the organization, I think.
Yeah, absolutely. I mean, it's all about building trust, right? I mean, at the end of the day, it's kind of like keeping a patient home is almost like a sale. It's like keeping that relationship ongoing. But there's a lot of life, a lot of things that take place in between. So at least having some way or form and fashion to communicate back and forth with a provider, a trusted provider, and building that bridge is so important. So, all right, we've got a new proposed rule for the 2025 home health conditions of participation. And really it's based around exactly what we're talking about today. I'm sure you've probably taken a look at it and done a little bit more of a deep dive than what I have. What are your thoughts?
So we see this happening in all sectors right now, to be more patient-centered and to really focus on this push towards value-based care and pay for performance. So I believe that this is just another example of trying to put some parameters around that. Kind of going back to what I said, with a lot of patients bouncing back because they don't have that timely start of care. That's been identified across the continuum. And I believe that's why we're looking at being able to get a more timely start of care and regulating that, because that's going to further impact the pay for performance and reimbursement rates, which they're already doing to hospitals tied to readmissions. And but it also streamlines the process. I talk a lot about that transition being when patient is most vulnerable. If we can cut down on that gap and have better communication, a more timely transition, it's going to, again, just lead to better outcomes for patients and accountability. Making everyone accountable for things that are more objective. If start of care is within 24 hours of the patient discharging, that's measurable. If it's, ever how they put that parameter around that, I think will be forcing us to look at how we're doing things and how we can do it better.
Yeah, and it kind of sucks for some that are doing the right things, right? I think that's in every industry. But hopefully this will deter, at the end of the day, some of those people that maybe are getting a referral electronically and they've got somebody behind the mouse, just click, 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 accept, and then picking up the phone, potentially calling the patient to be like, hey, can we come out tomorrow, right?
Electronically, then what we've seen, instead of having all the liaisons out in the field, you've got someone sitting at a computer and they're doing a real quick scan and they're like, do I take this insurance? Is it something? Accept. And it tends to go to whoever can accept and start the care the fastest, because hospitals are backlogged. They need the bed. So they're moving those patients as quickly as possible. So it becomes that who's responding the fastest, which can be frustrating. I know here in Arizona, I've had some of the post-acute providers say they're receiving electronic referrals over 6 or 7 different platforms. And some are really easy to use and some are very complicated to use. So it becomes that balance for them with how they are being able to consistently receive and review and make the right decision for the patient, not just saying, oh, take that insurance, I accept. That they're actually looking at the clinical information and identifying whether or not they can meet that patient's needs. I don't think it's that they're going anywhere. I said 52% use an extra. There's a whole nother that use some of the different functionalities within the EMRs. So it's still an electronic send. I've heard some will send a notice and say, I have a referral for you. And then the company has to log in and figure out how to review and find that. And again, I've not seen 2 EMRs be set up the same. So they have to learn all these different. So it's complicated for everyone when you look at almost conflicting pressures and priorities across the different levels of care. And that just negatively impacts the patient. So finding those opportunities to partner and make sure that everyone understands how to use what they're getting and what the expectations are. Sometimes that's a miss, I think, on both sides as well. What do you expect from your providers and how can we be better partners both directions?
That stuff. Let's talk a little bit more about what you do on your day-to-day now and what Strata and how Strata is really helping solve this problem.
Strata is a transition of care software solution, and we are a global organization. We have our technology in Canada, UK, Australia, and here in the US. It starts with that patient choice process. We have a database of all the post-acute providers. If you have a CMS ID, you're in our system automatically. But then we actually give the post-acute providers access to go in and to build out profiles, to be able to identify for home health, what zip codes are you able to service? Because depending on the state, that could be such a wide variety when you're looking at the different areas you're able to actually provide service. I think here in Arizona, we have 9 or 10 counties, and they're very large, very drawn out. So being able to say, yeah, we're in that same county, but we only do these 30 zip codes is important for the discharge coordinator to be able to show that to the patient. You're able to identify what payers you're able to accept, as well as being able to put right on your profile if you are open to doing a letter of agreement for one that you may not be in network with, because some have that flexibility, some don't. Any special services that you provide, any special programs that you may have, you're able to put that in our system. And then when the discharge coordinator is creating a list for the patient, they're able to filter it down and just show the patient those that are able to take. So if you can't take Aetna, you won't be on a list for a patient that has Aetna, which I think benefits both. The patient's not frustrated. They're not looking at, well, why can't they take me? Why'd you show them to me? And getting frustrated. Once they go through and the patient's able to look at all those options, it's an interactive tool that the patient's able to use. They're able to identify their top choices. Strata also has the full referral platform, and an area that has been very important to me as a leader in this organization is to have those communications with all levels of care. I think that so many are geared towards hospital needs or geared towards post-acute. Well, I meet with both. I want to know what in my system is going to make your life easier. How can I make this more equitable, and to help ensure that the patient is the focus. So we meet with both sides and ask for that feedback. And I personally really appreciate just how responsive the team has been to build out and support that technology that can go. There's also full communication tools within. We have the ability for post-acute providers to blast a message to all the hospitals in an area that utilize our platform to share that they have beds available or staffing available and what that looks like as often as they want. That's part of the system. There is instant messaging capabilities where it cuts out some of that phone tag, which really allows for efficiencies and improved communication backwards and forth. I've worked really hard to also try to standardize, make sure that the right information is going every time. I think that humans get busy and sometimes they may not send something that's important that should go, and that just creates delays and frustrations for everyone. So having consistent information be shared across the continuum for every referral, I think, is key, making it easy for everyone to see what was there and to build out those transparencies while creating an opportunity for collaborative care, keeping the patient at the center.
So hold on real quick, just to time out, just to make sure I understand this right. So I'm a home health care agency. You're a hospital discharge coordination team. I can go to Strata Health, fill out a profile of my agency online that then you have access to on your side. And so when you're discharging a patient, you can put in the credentials of that specific patient, and it's potentially going to pull up my agency as an option to then share with that patient. Correct?
100%. So whenever we onboard a new hospital, we actually have a team that does outreach to all the providers in that area. And we educate them. We make sure that they have access to be able to log in and to provide that information. And we serve as the bridge between the hospital and the post-acute providers to make sure that that data is updated and accurate. Of course, the hospital sends out the communication. Yes, we're doing this, all of that. But we build that out with you and make sure that you have the opportunity for success, just like we have for the hospital. So we have staff that support both sides of that continuum and really work to make sure that you're able to put your best foot forward. We even have some data available right within your profile that will show you whether you have a good, mediocre, or poor profile, and if there's anything we can do to help guide you to make sure that you are putting your best foot forward. Because once it's there, it's available to any hospital that uses the Strata platform. And that's one of the great things about it, is it's a nationwide database. There's over 80,000 post-acute providers in my database, and they're able to build out profiles. So I've worked most of my career in Arizona. We get a lot of winter visitors, and it was pretty common that, a patient would have an acute episode and they would want their follow-up care in their home state where their adult children may be. Back when I worked, we couldn't even go on Google. They had our computers so locked down. So we would be sitting and looking up hospitals in other states to call and say, hey, do you have a resource for us? Now with a tool like Strata Search, all of the providers are there. So if I have the zip code, if I have the city, I'm able to look at that area and get access to that information and still engage the patient and family. I can email out, I can text those lists, the interactive list, out to family members so they're part of the decision making. And it really just engages the patient and family, which we've seen leads to better outcomes. And I think it's a win-win when patients know what comes next and where they're going. They're more comfortable and they're able to get on with what needs to happen to get to their highest level of functioning that they're going to be able to get after whatever had occurred.
Yeah, that's amazing. So if any of our viewers are home healthcare agencies or even post-acute facilities that want to fill out their profile, so it is shared with the hundreds of other hospitals that are in your guys' database and those discharge coordinators that are using your solutions, how do they do that?
So they can go to stratahealth.com and there is a link to claim your listing. And we send you the login. We send a Calendly link so you can set up time with us to walk through it if you need assistance or want assistance. So that's all there. You can also just email, it's ussupport@stratahealth.com, and they're available to provide that support, answer any questions, and assist with that listing process. So you can claim your free listing and make sure that you're being highlighted appropriately and able to put your best foot forward.
That's amazing. Well, is there anything else that you wanted to share before we close out?
No, for me, the key here is we need better collaboration across the continuum of care. Value-based care is coming, and we're already seeing bundled payments, and we've got to break down these silos and work together as we are going to see an aging population hit fast and furious as the baby boomer generation continues to fill in that gap. And I appreciate you asking me to do this as well, Matthew. I love talking about healthcare and case management and how we can make a difference for patients, and just really appreciate this opportunity.
Yeah, for sure. Thank you so much for jumping on with me. This has been fun. And we'll have to do another one later on down the road once we get a little bit further, because you're right. I mean, value-based care it's here. I mean, it might not fully be here, but it's here without question. So we'll have to maybe do something else a little bit further down the road on some of the other stuff that we're seeing across, between the space and how communication actually is driving that. But until then, I guess I will chat with you later. Thanks so much for taking the time.